my point was not, is it a big problem? And are you hearing about this, in the hospital? Is there a drumbeat? My point is, it's actually beginning to percolate into the population.
Absolutely.
People are beginning to understand that not every antibiotic works, not every infection can be cured with what we've got, and to some degree, I'm not sure they have the sense that it's our fault, but it is, isn't it, to some degree?
I mean, it's not necessarily our fault so it is to some degree, because the simple answer is yes, but I mean, even appropriate use of antibiotics is going to lead to resistance development. So sure, we could mitigate it a little bit by more appropriate use, limiting unnecessary antibiotic use, but, and I would say that infection control plays a big piece of that story as well, but I mean, it's natural selection, right? I mean, we would expect this to occur, and as Andy pointed out, and I think it's an important thing to keep in mind, is that we keep people alive longer now for things that they used to not be able to survive, and they end up becoming the poster children for getting these drug-resistant infections.
But I'm going to disagree with you a little bit, Jason.
How
because,
dare you?
How dare you? I know this shocks you and all the people who know
We've
me
never disagreed once.
in the last 7 minutes.
You're so easy to get along with.
It's fascinating. I'm fascinated. But to bastardize Shakespeare, I disagree. I think the fault does lie with ourselves and not with the stars. This is not something where we should have stepped back and said this was inevitable, there was nothing we could do. This has been watching a slow motion car crash for a generation, and we're still playing catch up. And we've created the problem and we have to fix the problem. And each one of us in our roles as clinicians, whether in the SICU, the MICU, ER, on the floors, as a PharmD, we have all contributed to this, and it is incumbent upon us to figure out how to solve the problem, period.
I think getting back to the question about more information in the community, with the increase in C. diff, I think a lot of people, lay people, are aware of C. diff, and they are starting to be aware that it's associated with overuse of antibiotics. So this is starting very slowly to be a topic that's discussed outside of hospital settings. But while we've worked on antimicrobial stewardship a lot over the last decade in the inpatient setting, it's really just starting to even be discussed as a need in the outpatient setting.
This gets back to what I was saying. I mean, this is a lot of deaths, 23,000.
It's a lot, and I think I have to piggyback on Andy's comment when he said, we're to blame, it's been occurring over decades. But there's a bigger issue called One Health. 70% of antibiotics in the United States are actually prescribed to animals. And so when you look at the animal to human transmission of resistance, there's a big component right now of sort of who's to blame. So yes, healthcare providers are part of it, but responsible use in the animal sector is another part, and it's kind of becoming a blame game, which will never solve it. It's a responsibility amongst all of us.
How about we just accept the fact that there's enough blame to go around?
Right.
Absolutely.
And we're all in the same boat. So let's take a look at the impact. I mean, yes, it's beginning to percolate, and the point is, if everybody realized that was a lot of 747s crashing, maybe there'd be some outcry here. Until that happens, people have to understand the impact. So first of all, what is the clinical and then the economic impact here on the hospitals per se?
Yeah, I think the clinical impact is best described on the patient. Again, pick your favorite resistant organism and look at outcomes in patients who have an infection due to the resistant form compared to the susceptible form. And what you're going to find across the board are twice as worse outcomes. Mortality rate doubles. If the patient survives, length of stays double, the need for extra care afterwards. And again, from the hospital standpoint, there's a cost associated with every single one of those things.
How many of these resistant bugs are hospital acquired? How many out in the community?
I mean, in my opinion, or based off of kind of what we see, the majority of them are some exposure to the healthcare industry, but there are certainly versions of these that have transmitted out into the community. MRSA is a good example of that. You can certainly see patients with purulent skin infections from the community that's community-acquired MRSA. We can see it in community-acquired pneumonia from time to time as well. And even in the gram-negative space, we've started to see that occur, and ESBLs are the real example there. That was traditionally a nosocomial pathogen, and as the epidemiology changed, you saw this push out into otherwise healthy individuals.
Jason, a good example of that is young women who acquire their first urinary tract infection, and everybody thinks, oh, no big deal, you give a couple days of Cipro and call it a day, except when it doesn't work. And so we're seeing patients that have never had healthcare exposure acquire their first E. coli UTI, multidrug resistant, and I think the best example is a 23-year-old model from Brazil who was exactly that scenario, got her first UTI, got a 3-day course of Cipro, except it was resistant to everything, and she ended up dying. And that put it on the, she was the face in Brazil for that statement of, we're in a crisis. And so that's a big problem.